joined in. Right. So we've got today Dr. Nishanta Lienapathirana, consultant urological surgeon from Teaching Hospital Anuradhapura, and we'll be doing an observed history taking today, and he will be the examiner, right? So you can take the history, the model history, and then he will be questioning you on the history, and also you can carry on the discussion. Dilup?
Yeah.
You have the history.
Sakuni.
Yes, sir.
All right. Right. So you have about 10, 11 minutes. So shall we start then?
Okay, sir.
Okay.
All right. Just a quick question, Pramod. Are these all the final MBBS students?
There are some fourth years and third years joining as well, I think.
Yes.
All right.
Mostly it's final year, sir.
All right. Okay. Right. Great.
Okay, Sakuni,
Okay.
go ahead.
So we'll go ahead. Yeah.
අයිබෝවන් මම රාගම් වෛද්‍යකීපේ වෛද්‍යශිෂ්‍යෙක්. මම ඔයගෙන් ප්‍රශ්න කිහිපයක් අහුවට කමක් නැද්ද? හලෝ.
Sakuni, කියන්න.
ඔයගේ නම මොකද්ද?
මගේ නම චන්දන.
චන්දනගේ වයස කීයද?
දැන් 65ක් වෙනවා.
පදිංචිය කොහෙද චන්දන?
පදිංචිය මාතර දැන් ඉන්න නම් මේ බෝඩ් වෙලා කටුනායක.
කටුනායක බෝඩ් වෙලා මොන හරි රස්සාවක් කරනවද?
ගාමන්ට් එකක ලයින් එක සුපර්වයිසර් කෙනෙක්.
ලයින් එක සුපර්වයිසර්. එතකොට ඔයාට තියෙන්නේ ගොඩක් ඇවිදින වගේ රස්සාවක්ද? එහෙම නැත්නම් දවසේ වැඩි වෙලාවක් වාඩි වෙලා ඉන්නවා වගේ රස්සාවක්ද?
ඇවිදින්න තමයි තියෙන්නේ.
ඇවිදින්න තමයි නේද? එතකොට මේ චන්දන විවාහකද?
ආකයි.
දරුවෝ හැම ඉන්නවද?
ලොකු දෙන්නෙක් දෙන්න.
මේ වයස කීයද වගේද ඒගොල්ලන්ගේ?
වයස එක්කෙනෙක්ට 25යි අනිත් එක්කෙනාට 20.
මේ චන්දන මොනවා වෙලාද ආවේ?
මාස 3-4 ගෙනන් නිකන් මුත්‍රා කරද්දී එච්චර හොඳට විදලා යන්නේ නැහැ අමාරුයි වගේ හිතනවා එහෙම තිබුණ නැහැ ඒක පෙන්වන්න තමයි ආවේ.
මුත්‍රා යන්නේ නැහැ ඒ කියන්නේ අමාරුවෙන් වගේ තමයි යන්නේ. තා ටිකක් පැහැදිලි කරන්න පුළුවන්ද මේ අමාරුව මට?
ඉතින් මුත්‍රා කරන්න ගියාම ඉතින් හොඳට ටිකක් තටමල මුත්‍රා කරන්න වෙනවා වගේ හැඟෙනවා. ඒක තමයි අමාරුව.
ඒක තමයි අමාරුව. ඒතකොට මේක මාස 2-3ක් තිස්සේ විතර
මාස දැන් 3-4ක් වගේ තිබ්බා වගේ තමයි.
3-4. හරි. එතකොට ඔයාට මේ මුත්‍රා කරන්න පටන් ගන්නත් අමාරුයි වගේ තියනවාද?
ඔව් මුත්‍රා කරන්න ගත්තාම මේ ගොඩක් තටමන්න ඕන පටන් ගන්න.
තටමන්න ඕනේ. පටන් ගත්තට පස්සේ මුත්‍රා කැඩි කැඩි වගේ දෙයක් නේ.
ඔව් දැන් මාස මේ මුලදී නම් එහෙම තිබුණේ නැහැ. දැන් ටිකක් විදලා යන්නේ නැති ගතියක් එහෙම නිකන් කැඩි කැඩි යන ගතියක් මම නෝනා කියනවා වගේ තේරෙනවා.
එතකොට විදලා යන්නේ නැහැ නේද?
ඔව්.
මුත්‍රා. එතන මුත්‍රා ගිහිලි වුණාට පස්සේ අන්තිම ටික නිකන් බින්දු බින්දු යනවා වගේ ගතියක් තියෙනවද?
ඇඳුම් වල එහෙම ගතියක් තියෙනවා ගෑවිලා තියෙනවා වගේ තේරලා තියෙනවා මට.
තියෙනා නේද? එතකොට දැන් ඔයාට මුත්‍රා කළා ආපහු තව ටික වෙලාවකින් ආපහු මුත්‍රා කරන්න යන්න අවශ්‍යතාවයක් තියෙනවා වගේ තියෙනවද?
ඔය එහෙම ඉඳලා හිටලා එහෙම තේරෙනවා ලයින් එකේ වැඩ කරන් යනකොට ඉතින් මුත්‍රා කරත් ආයෙසරයක් නිකන් ටිකක් පිරීලා වගේ එහෙම ආයෙ යන්න ඕන වගේ එහෙම තේරෙන අවස්ථා තියෙනවා.
සාමාන්‍ය මුත්‍රා කළ පැය දෙකක් ඇතුළත කාලය ඇතුළත ඔයාට තව කීපාරක් වගේ යන්න ඕන වෙලා තියෙනවා යන්න ඕන වෙනවා.
පිටින් මිට එහෙම සැරයක් දෙකක් යන්න වෙන අවස්ථා තියෙනවා.
තියෙනවා. එතකොට වෙනදට වඩා මුත්‍රා කරන වාර ගණන වැඩි වෙලා වගේ තියෙනවද?
ඔයෝ දැන් ඉස්සර වගේ නෙමෙයි දැන් දවල් වරුවේ 5-6 වතාවක්
5-6 පාරක් යනවා නේද? මේ මුත්‍රා බර වලට දරාගෙන ඉන්න පුළුවන්ද? එහෙම නැත්නම් මුත්‍රා බර දැනෙද්දි නිකන් ඉක්මනට මේ වෙලෙම පිට කරන්න ඕනේ වගේ එහෙම නැත්නම් මුත්‍රාවම ඉබේම ඇඳුම් යනවා වගේ තියෙනවද?
නම් යන්නේ නැහැ. ඉතින් දරාගෙන ඉන්නත් බැරි කමක් කොහොමද තියෙනවා ඕන ඕන වෙලාවට යන්නත් බෑනේ.
ඔයාට රැට නිින්දෙන් හැරිලා මුත්‍රා යන්න ඕනේ වගේ වෙනවද?
රැට ඉතින් සමහර දවස්වලට 2-3 වෙලා හැරෙනවල් තියෙනවා.
එතකොට ඒ වගේ වෙලාවට රැට නිින්දෙන් කීපාරක් වගේ හැරෙනවද?
එක සැරයක් වගේ තමයි.
එක සැරයක් වගේ. මේ ඇඳුමේ නොදැනුවත්ව රැ මේ මුත්‍රා ගිහිලා තියෙනවා වගේ තියෙනවද?
නෑ එහෙම කවදාවත් වෙලා නෑ.
එහෙම නෑ. එතකොට මේ මාස 3-4ක කාලය ඇතුළත මේ ඔයාට මේ දැනෙච්ච අපහසුතාවය එන්න වැඩි වුණා වගේ තිබ්බද?
ඔව් දැන් ටිකක් අමාරු වැඩි.
වැඩි වගේ නේද? එතකොට ඔයාට කවදාවත් රතු පාටට මුත්‍රා යනවා වගේ දැනෙලා තියෙනවද?
රතු පාටට එහෙම බලලා නැහැ එහෙම හැබැයි මම දැකලත් නැහැ.
දැක්කලා නැහැ. මේ දවස පුරාම තියෙන තුනටිය කැක්කුමක් වගේ තියනවද නිකන් ওই පැනඩෝල් පෙත්තක්වත් බිව්වට හරියන්නේ නැති වගේ.
තුනට එනන්නේ යටිපතුල් කැක්කුමක් නම් එනවා ඉතින් ඇවිදින හින්දා වෙන්න ඇති.
තුනටි කැක්කුමක් ඒ වගේ නෑනේ කොන්ද කැක්කුමක්.
නෑ.
මේ බර අඩුවීමක් හරි කෑම අරුචියක් වගේ ගතියක් තියනවද?
බර නම් පොඩ්ඩක් වැඩි වුණා කියලා තමයි හිතෙන්නේ ළඟදී කෑම අරුචියක් නැහැ.
නෑ නේද? ඔයාගේ මේ මුත්‍ර මාර්ගයාවට මේ කලින් මොන හරි ඇක්සිඩන්ට් එකක් හරි එහෙම වෙලා මේ මොන හරි ඒ වගේ අපුණාවක් වෙලා තියනවද?
ඒ ඇක්සිඩන්ට් නම් වෙලා නැහැ.
ඒ කියන්නේ මේ ඇක්සිඩන්ට් එකකින් පස්සේ නිකන් මුත්‍ර මාර්ගයෙන් ලේ ඇවිල්ලා තියෙනවා ඒ වගේ?
නෑ නෑ එහෙම මොකුත්.
එහෙම. මුත්‍ර මාර්ගයට බට දාලා හරි මේ පරීක්ෂණ එහෙම හරි මොන හරි කළා තියෙනවද?
කවදාවත් නෑ. කවදාවත් නෑ.
නෑ. මේ කලින් මුත්‍ර ගල් එහෙම තියනවා කියලා මේ දොස්තරලා මොන හරි පරීක්ෂණ කරලා තියනවද?
අපේ මාමණ්ඩිට නම් තිබුණා මේ මට නම් එහෙම
තිබිලා නෑ නේද? මේ ඔයාට යම් කිසි කාලෙක කොඳුයට පෙළේ මොකක් හරි හානියක් වෙලා හොඳ වෙලා වගේ තියනවද?
නෑ. එහෙම මොකුත් වෙලා නෑ.
අංශභාග තත්ත්වයක් වගේ තිබිලා තියනවද? හලෝ?
එහෙම නෑ. සකුණ කියන්නේ.
මේ ඔයාට මේ සීනි එහෙම තියනවද? සීනි වැඩි කියලා එහෙම දොස්තරලා කියලා.
ළඟදී චෙකප් එකක් කරා සීනි ප්‍රෙෂර් මුකුත්ම තිබුණේ නෑ.
මුකුත්ම නෑ. එතකොට මේ ඔයාට මේ දැන් මේක මාස 3-4ක කාලයක් ඇතුළත වුණා කියලා කිව්වනේ. ඒ කාලය ඇතුළත උණ එක්ක මේ මුත්‍ර දැවිල්ල වගේ ඇවිල්ලා තියෙනවද?
මාසයකට විතර උඩදී නම් පොඩි වෙවුලිල්ලක් එක්ක වුණා. මුත්‍රා දැවිල්ලකුත් කියනා වගේ තිබුණා. ඒකට ඉතින් බේත් ගත්තා ඒ වෙලාවේ.
බෙහෙත් ගත්තා. මේ මොන හරි මේ මුත්‍රාවල විෂ බීජ වාර්තාවක් වගේ දෙයක් කරලා මොන හරි
ඔව් අර මොකද්ද දවස් 3කින් විතර රිපෝට් එකක් ගන්න එන්න කිව්වා මට යන්න ඕනේ නැහැ ඒක ගන්න.
යන්න ඕනේ නැහැ. ඔයා බෙහෙත් පෙතිද බිව්වේ විදලාද? බෙහෙත් විද්දාද?
නෑ බේත් පෙති තමයි දුන්නේ. ඒක ගිය දවස් 4-5 යනකොට මං ඉතින් ඒක අතල්ලා දැම්මා ඉතින් එහාට.
එතකොට ඔයාට මේ මාස 3-4 අතරතුර මේ සම්පූර්ණ මුත්‍රා අඩස්සි වෙලා ඉස්පිරිතාලට ඇවිල්ලා මුත්‍රා බටයක් දාන්න වගේ වෙලා තියෙනවද?
නෑ එහෙම නම් උන්නේ නැහැ.
එහෙම. එතකොට ඔයාට නිකන් අධික තෙහෙට්ටු ගතියක් වෙන්නදට වඩා නිකන් වමන යන්න එනවා, ඒ මස් පිඩු පෙරලෙනවා, ඒ වගේ ගතියක් දැනෙලා තියෙනවද?
නෑ අඟපතට ඉතින් හොඳට පණ තියෙනවා එහෙම අමාරුවක් නැහැ.
පොඩි වැඩක් කරත් නිකන් හුස්ම ගන්න අමාරුයි, ඒ වගේ ගතියක් තියෙනවද?
ඒක කරන් යනවා.
මේ සම්බන්ධයෙන් දැන් ඔයා මීට කලින් වෛද්‍යවරයෙක් හම්බ වෙලා තියෙනවද මේ ප්‍රශ්න සම්බන්ධයෙන්?
ගාමන්ට් එකේ ડોක්ටර්ව හම්බුණා. ඉතින් බල්ලා මේ පස්ස පැත්තනොත් බැලුවා පොඩ්ඩක්. මේ බල්ලා කිව්වා මේ පොඩි ප්‍රශ්නයක් තියෙනවා වගේ පේනවා. මේ මෙහෙ බේත් කරන්න බැරිද? මේ ඉස්පිතාලේ යන්න ඒක තමයි ආවේ.
ඒකට තමයි ආවේ නේද? ඊට පස්සේ ඔයාට කලින් දැන් සීනි ප්‍රෙෂර් නැහැ කිව්වනේ. මේ පපුවේ අමාරු ඇදුම වගේ අසනීප තත්ත්ව තිබිලා තියෙනවද?
එහෙම මුකුත් ගෙතක් ගන්න ලෙඩක් හැදිලා නැහැ.
අරිෂ්ඨ වර්ගයේ වගේ වල මොනවත් අරගෙන නැහැ නේ?
නෑ එහෙම එච්චර පාවිතියක් නෑ.
නෑ. මේ කලින් ඔපරේෂන් මොනවද කරලා තියෙනවද?
ඔය පොඩ්ඩක් ඔය එහෙම මෙහෙන් ඔය පොඩි තුවාලයක් වෙලා කැපුමක් වෙලා මැහුමක් දාලා දෙසරයක් විතර තියෙනවා. ඊට එහා මුකුත් නෑ.
ඒ හිරිවට්ටලද කරේ? හලෝ?
ඔව්
මේ ඔයා බෙහෙත් ප්ලාස්ටර් කෑම වලට වගේ මේ කහල පළු දාලා මේ ඇලර්ජික් වෙලා වගේ තියෙනවද?
ඔය අන්නාසි වලට පොඩ්ඩක් පළු දාන ගතියක් තිබුණා ටිකක් තරුණ කාලේ. දැන් නම් එහෙම මොකටවත් නැහැ.
නෑ නේ. මේ ඔයාගේ නෑදෑයන්ට මුත්‍ර මාර්ගයේ හරි වෙනත් කොයි හරි පිළිකා තත්ත්ව වගේ මොන හරි තිබිලා තියෙනවද?
නෑ එහෙම මොකුත් දන්න තරම්.
දැන් ඔයා මේ බෝඩ් වෙලා කියලා කිව්වනේ ඉන්නේ. එතකොට මේ ගෙදර එහෙම හොයලා බලලා එහෙම උදව්වක් තියනවද ගෙදර කට්ටියගෙන්?
ඔව් ඉතින් ඒගොල්ලෝ බලනවා මේ ලොකු පුතා ඉන්නේ මේ ගාමන්ට් එකේම. ඒකින්ද ඉතින් ප්‍රශ්නයක් නෑ.
එතකොට මේ ඔයාට දැන් නැවතිලා ඉන්න බෝඩින් එකේ වැඩපළේ
concerned about the time also.
7 minutes 40 seconds sir.
Yeah.
Sorry, you can finish.
Okay.
එතකොට මේ ඔයා සිගරට් අරක්කු වර්ග වගේ එහෙම පාවිච්චි කරනවද?
ඔව් ඉතින් කොල්ල කාලේ නම් ඉතින් පොඩ්ඩක් සිගරට් එකක් බිව්ව අරක්කු නම් බීලම නෑ. දැන් සිගරට් බොන්නේ අවුරුදු 10ක් අත යනවා.
බොන්නේ නෑ නේද? එතකොට මේ ඔයාට දැන් මේ වැඩපළේදී බෝඩින් එකේදී වගේ වැසිකිලි භාවිතයට ඒ වැසිකිලි තත්ත්ව එහෙම තියෙනවද? මේ හොඳ තත්ත්වෙන් තියෙනවද පාවිච්චි කරන්න පුළුවන් තත්ත්ව?
ඔව් ඒක නම් එහෙම ප්‍රශ්නයක් නෑ. ඒ අලුතෙන් හදපු කම්පැනි.
එතකොට ඔයාගේ ළඟම ඉස්පිරිතාලේ මොකද්ද?
ළඟම ඉස්පිරිතාලේදී මේකම ඉස්පිරිතාලේ තමයි.
ඔයාට හදිසියක් වුණාම මේ බෝඩින් එකේ හරි වැඩපළේ ඉඳලා හරි අරන් යන වාහනයක් වගේ තියෙනවද කතා කරගන්න පුළුවන්?
කතා කරගන්න පුළුවන්.
හරි.
Right. Okay. Thank you.
Right. Nishanta, usually, as per the new protocol, exam protocol,
Yeah.
we usually the two examiners are observing the history taking, and then we give them about 10 minutes to sort of formulate their summary and examination as well. After the history, there is examination, and then
10 minutes to organize their thoughts.
3 minutes to organize that. So after the history, there is a separate time for the examination, right?
No, they get 15 minutes for history and examination both.
Yeah, so now she took about 10
so
minutes.
They themselves can sort of decide on the allocation of time. But at the end of 10 minutes, examiner will remind them if they haven't already started examination.
Yeah. Okay. So now, since this online forum, shall we ask Nishanta to comment about the history taking, whether he was happy or?
Yeah, how do you want me to sort of do it? I mean, do we have to let her prepare the presentation, or are we going to just go ahead with the discussion from here onwards? How do you like to have it?
We will discuss about sort of the important points of the history, which I think he has sort of covered. And examination, as we couldn't do today, but we can ask her the important aspects where she pay more attention during the examination. And then we'll get a summary from her and proceed from there.
Yeah, okay. All right, great, that's fine. Okay, sorry, I didn't get your name again. What's your name, doctor?
Sakuni, sir.
The Sakuni, okay, Sakuni. Right, Sakuni, basically your history taking is fairly, I would say, okay for a final MBBS student. A few things that you have elicited is quite important, because these sort of cases are like, you know, just basically low unit tract symptoms and bladder outflow tract obstruction. You had to elicit most of the things in your history, right? So you don't have much of examination findings here. And most of the time, the finding during final MBBS, I don't know, certain faculties, they give you the PR findings or the corrective findings, but some of the faculties, you know, let you examine. But all in all, your history taking, the way you elicited the low unit tract symptoms is good. But what is important is to put it into a nice summary and present it to the examiner in a way that you have gone through all. So that's another set of skills that you have developed. So I would say that is quite okay. But few things I would like to highlight. Immediately when you asked about the frequency, asked about daytime and nighttime frequency, because then you won't miss it and it'll be more complete. The other thing is, when somebody says low unit tract symptoms, how old is this guy? How old is this guy, Sakuni?
60 years old.
60, yeah, okay. Anybody around the age of 55, 60, and they complain of low unit tract symptoms for 3 months, you had to always walk them back and then ask them whether you got sort of, when was this sort of initial symptoms? Have you ever had some sort of a sluggishness of the flow for about a couple of years? Then they'll come up with the story that they may have had it time to time for about last maybe 3, 4, 5 years. So we know that it is nothing, something is acutely worsening. So that is one important thing. Then you elicited the visible hematuria, but had always asked about the dysuria, which some of them has got. So those are common associated features, and if they have any visible hematuria, you need to go into detail. Then your symptom analysis is quite okay, and then when it comes to differential diagnosis, you had to come with some sort of a structure in your history Well, there are many recommendations. Some people would like to go ahead with benign and malignant, and some of the examiners would like to go ahead with sort of more of an oral view. But you asked many of the benign conditions, and I'm impressed that you asked about the neurology also. But one of the important a guy with a 3 months history, one of the important condition that you need to ask is a Kodai-Kuna syndrome. If you are a bit smart, I mean, it's not a must, but if you can elicit, you can go for a much higher score because you have scored because you have thought of neurological condition. Then the differential diagnosis, I'm happy about the questions that you asked. But one of the things that you could have asked specifically when you asked about the stones, about the bladder stone, you had to elicit the history of a bladder stone, the typical history of a bladder stone, and you had to show the core knowledge to the examiner that you know about the classical presentation of the bladder stone, and you're confident about the excluding or finding out whether he has got clinical features of bladder stone. Then again, the systematic inquiry, I would say when you ask about the systems, we always in surgical history taking, we think of systemic involvement or the complications of a particular disease. We always see in the context of cancer. So if it is cancer, whether there are any other organ involvement. You elicited about the back pain and loss of appetite, but you have to always think the prostate cancer doesn't always, limited to the spine or the bones. Sometimes it can go to the viscera, can go to the liver, lung, which I haven't seen that you eliciting those. Then, and trauma, if you are a bit smart, you can, at least when you're summarizing, you can say whether there is any history of fallen asteroid or whether there is any particular history of RTA or fallen from height. Then, luckily, whether I don't know whether it's you or the patient himself volunteered about the UTI. UTI, you need to know how many episodes of UTI. Even a single episode in a male is important, but that's very important to elicit. Then I'm glad that you elicited the history of acute retention. Then the other complications, like renal failure, you need to be a little bit more sort of targeted about the questions or clinical features of renal failure, body ankle swelling, facial edema, and all these things. I mean, it's very unlikely in acute retention, but we would like to elicit. I mean, if you can elicit, it would be good. And then, the aspirin and clopidogrel, you have to straight away ask. Nowadays, people are very sort of knowledgeable and they know what sort of drugs they take. So we had to specifically ask aspirin, clopidogrel, warfarin. So that's a must, and that's a management changing finding. So that is very important, and we'll be very upset if you don't elicit them, if the patients are on any of these antiplatelets or anticoagulants. Yeah, I think other than that, the social history and everything, I'm happy. I don't know whether Sumudisa or Pramod has to add anything else.
Yeah. Now, assuming that she had time for examination, we don't usually expect them to examine do the PR exam. Apart from that, what sort of an examination would you expect if this was given as a long case? What are the areas that they need to focus on specifically?
Yeah.
For this period?
Yeah. Sure. So we could ask Sakuni herself. Sakuni, what would you think important in this patient? If you just tell quickly. Are you there with us?
Yes. In a general examination, I look at the build of the patient and if he's catheterized or if there's like a smell of stale urine, and if there are the features of renal failure such as features of anemia,
yeah.
such as pallor and any nail changes, such and such. And if he has dry skin or ankle edema. And on the abdominal examinations, I'd more look at look if there's any visible abdominal distension or scars and any abdominal tenderness, and I'll make sure to check for the palpable bladder and
palpable bladder. So that is one of the findings that we would like to look into. What anything else?
If I can find any palatable masses or like the palpable kidney, and I would offer to look at the external genitalia to see if there is any evidence of meatal stenosis or a phimosis.
Yeah, very good. So you need to do the genital examination, thorough genital examination, at least the things that you can see, even if you are not allowed to do colorectal examination. Well, the other important thing is like, what the after effects of the long-term bladder outflow obstruction. You had to specifically look at for the hernial orifices. You had to always think about, these patients having if he's got these symptoms for a long time, there is a possibility that he might have some hernia. And if you can bring them out, if we can sort of specifically, if the examiner asks you, okay, what are your examination findings, important ones, you can always mention those things, which will carry you additional marks. And external genitalia. Any particular thing that you'd like to see in external genitalia? Meatal stenosis, you said. You heard of any condition called BXO, balanitis sclerotica obstetricans?
Yes, sir.
Yeah, okay. So what is the typical feature of BXO? The depigmentation, right? The vitiligo or depigmentation. I wonder whether I can, for the benefit of the other people, I'll just see whether I can share this slide.
You can.
Yeah, can you? Okay, let's see. Right. Can you see my slide?
Yeah.
So can you see the slide? Yeah. Okay. So in BXO, you just wanted to see. It's basically the involvement of the prepuce. It always starts from the distal to the proximal. So you get the preputal involvement, depigmentation. You can see nicely here, and then that thing is usually spreading into the meatus. So there are two different things in the external genitalia. That one is the preputal opening, and the second one is the meatal opening. These are two different things. So preputal stenosis and meatal stenosis, both are results of BXO. You can see very clearly in the other picture the depigmentation. Doesn't always carry a stenosis, but that's how the BXO starts. Right. So that is one of the important things. Then the rectal examination, of course. Yeah.
Sir, is BXO is it a pre-malignant condition, sir?
It is a pre-malignant condition, but it's not. It's not important to discuss in the long case. But yeah, it is a pre-malignant, and you can get it in your MCQs. Then other than that, the prostate examination. What important factors we are looking at here when you say prostate examination, or we call it rectal examination, right, rather than prostate examination. So what are the important things that you need to elicit here? Two things, sphincter and the prostate. So you have to always comment about the sphincter, because sphincter is a sort of surrogate indicator of a neurological supply to the S segment, because sometimes it shares it shares the neurological supply of the external sphincter also, the sphincter urethra. So that is important that you mention about the sphincter, and then the prostate. So what particular things that you look in the prostate, Sakuni?
I would feel for the prostate and see the surface and if the consistency, and if I can feel a median groove and if I can freely achieve mobility of the rectal mucosa.
Yeah, consistency. We would like to hear whether it's a sort of a firm prostate or I mean very. We won't call it hard, but we call it. I mean, at your stage, if you call it hard, we would agree if it is malignant. Okay. So what else? Median groove, yeah, and then the mucosal mobility, and whether you can feel any nodules. At your stage, if you can give some basic information about the prostate, we are happy as a final MBBS student. So yeah, so those are the important things. And then yeah, whether the prostate is tender or not. So those are important. Right.
What's the importance
Then,
of tenderness, Shanta? Why do you want?
Yeah. So all right. So especially, I mean, not. I mean, at this age, even at this age, sometimes you can have a prostatitis as a presentation. You know, patients with bladder outflow obstruction. Sometimes they can have acute bacterial prostatitis. If they have residual volume of urine, they can have a little bit of a urine reflux through the ejaculatory ducts, and they can have a little bit of a features of acute prostatitis, but it's very rare. But you know, we would always like to see in a patient who complains of a short duration fistula like this, whether they have any features of acute prostatitis. But then acute prostatitis, prostate will be very tender. So we would like to know whether there is any tenderness or not. I think basically that's what we wanted to know in the examination. And if you are smart, you can just mention about the general neurology of the patient, because you know these low unit tract symptoms are associated with a lot of neurological conditions, as I already mentioned, cauda equina, and also many of these patients like you know Parkinson, and then patients with multiple sclerosis and any neurological problem, they can have low unit tract symptoms because you know the bladder nerve supply of the bladder and the sphincter can be disturbed. So that is, I wouldn't say, I mean, some of these things are essential and must. Some of these things are nice to tell. So if you won't be penalized if you don't tell them, but if you tell them, you will get additional marks. But just just don't tell them at the beginning, you know, just at the end, just the top of the icing of the cake. So just at the finishing remarks, you just mention those things. If you were asked to sort of present your examination findings, but in a summary, I mean, if it is not there, you shouldn't be putting it. You just say the neurology is normal, so that is acceptable. Yeah, I think that's what we basically want.
Yeah. So if you are to mark Sakuni's history taking out of 10, how much will you give her?
I would say, I mean, she, except for the metastatic features of a possible, you know, visceral metastasis or prostate cancer, other than that, basically, you are basically passed from the examination history taking point of view. I would say somewhere around 60 to 70, I would say. And if you add the other bits and pieces, you could easily score around 80, 85, 90, maybe. But yeah, definitely around 60 to 70 level. Yeah.
Right. Good.
Thank you,
So
sir.
shall we continue the discussion from there onwards, assuming
Yeah,
that she has
sure.
presented this history? Right. So
Okay.
yeah,
We could go ahead with the
yes.
summary, isn't it?
Yes.
And
Sakuni, are you
yeah,
ready
the
to give
others,
the summary?
anybody who want to ask any question, you can just direct it into the chat box. Yeah, we could just give you some answers. Pramod, do we have any sort of particular time limitation for this discussion? When should we finish it?
No. You can carry on.
Okay, just let me know.
Yeah,
right. Sakuni, can we have a summary of the case, please? So forget about the examination findings. Just give us a summary based on your history.
Mr. Chandana is a 65-year-old father of two from Katunayaka who works as a supervisor in a garment factory. Yeah, he's previously healthy and this time presented with symptoms of bladder outflow obstruction for 3 to 4 months duration with prominent voiding symptoms associated with some storage symptoms. He had one episode of lower urinary tract infection as a complication, but had no episodes of acute retention. This poses a significant impact for his day-to-day life. There was no sinister symptoms in his clinical history and no significant past medical, surgical or allergic history. His yes.
Is he on any anticoagulation or not? Just let us know. Right? So so you said that he's not on any medication, so that's good enough. Okay. Right. So now this is a 60-year-old man coming to you with low urinary tract symptoms. Because, well, just for the benefit of everybody, we'll just go through. I'm just not going to sort of give you a comprehensive talk on bladder outflow obstruction, but we just let you know a few of the important things that you need to brush up and you need to review when you talk about bladder outflow obstruction case, right?
Nishant,
so,
shall we sort of continue the exam scenario? You can question.
Yeah, that's right.
We'll go to the discussion later on. Right? If this is the final exam,
okay. Yeah,
present this summary.
Yeah. Okay. So yeah.
Yes, Nishant. Now
definitely
the new format.
Yeah.
After organizing their thoughts, they get 10 minutes to discuss with in front of two examiners. So based on
that. So we'll put the timer on and we'll ask questions for during 10 minutes.
Yeah.
Okay, great. Right. So okay, Sakuni. So this is a 60-year-old man comes to you with these sort of symptoms. Do you how do you sort of investigate on this man? Or give me some differential diagnosis for this man first.
The most for the differential diagnosis, I like to say benign prostatic hyperplasia,
okay,
prostate cancer,
okay,
and any bladenic stenosis or hypertrophy or urethral stricture.
Yeah, urethral stricture. Okay. All right. Sakuni, can this be a case of bladder stone?
He does not typically complain of any pain in the specific suprapubic pain or pain referred to the tip of the penis.
What do you call that? What do you call that? What do you call that symptom? You heard of a terminology called stranglery?
Yes.
Okay. All right. Right. And then what is there are two features. One is stranglery, and what is the other important clinical feature of a bladder stone?
The pain is induced by movement.
Well, that is not so typical. The other typical thing, the sort of
painful
flow will be,
hematuria.
well, you get all this, but the two important things is triangular and then intermittent flow. Some patients will tell the flow goes on and then shuts down and then again restarts and then shuts down. Okay, right. So those are the differential diagnoses for you. How would you investigate this man? What are the tests that you wanted to do?
I would take a urine full report and I would look at any evidence of pus, blood, white blood cells, and I would also look for a urine culture and ABSD.
Okay. What is significant? What is the significant amount of RBC in this man's urine full report?
In a male patient, more than 3 red cells per high power feet.
Yeah, good. Okay. So that is what is called as a microscopic hematuria, right? Okay. And then what else you want to do? UFR?
And a urine culture and ABSD.
Okay.
And then I would look at serum creatinine and blood urea to see if there is any renal impairment caused due to this bladder outflow obstruction.
Okay.
And
so you said you wanted to do a culturing of the urine, and why are you concerned about the infections here?
Because infection is one of the common complications of bladder outflow obstruction. And as he has already had one episode 1 month back, it would be important for me to see if there is any.
Does it change your management if you are the doctor who's looking after this man or seeing this man in the clinic? Does it change your management if he's got infection? Okay, in another word, male with UTI, is it a common thing?
No, sir.
Female with UTI, is it a common thing?
Yes, sir.
Yes, but a male with UTI is always abnormal, right? So, okay, we'll come to that in the management bit, but the recurrent UTI urinary infection is one of the indications for non-medical management. Okay, so that is important. All right, so then you talked about some of the differential diagnoses. Tell me about the specific investigations you would like to do in this case.
Sir, I would like to do a prostate-specific antigen.
Why would you do a prostate-specific antigen?
Because if it, even though it's not specific to prostate cancer, but more specific to the prostate, if it's more than 10, as there would be a high suspicion of malignancy, we would have to investigate along that way. So I'd like to exclude that as well.
Okay, right. So tell me about something about the PSA. You said, cutoff value of 10. Is it the same in all patients, or PSA of 9? Is it not significant if you see this man in the clinic?
Usually, sir, the normal cutoff value is 4, less than 4. So
yeah,
more than
that is what we
4,
want.
yes.
So right, more than 5 is always abnormal, right?
Yes.
4 and 5. More than 5 is not 10, right?
Yes.
Okay, so anything around 10 is abnormal, right? Okay, so you said that it is not specific for prostate cancer.
Yes.
So which means you might see another sort of situations where the PSA can get elevated.
Yes.
Can you tell me some of the conditions?
It can elevate in benign prostatic hyperplasia, or if there is any if it's after the like a digital rectal examination, vigorous digital rectal examination, also the it can give higher false high results. And
so you need to, this is one of the common
and in
prostatitis
prostatitis it can also.
Okay.
Yes.
Right. So digital rectal examination doesn't cause significant elevation of the prostate PSA, right? It causes about 0.1 to 0.2. Okay. So digital rectal examination does not change the value of the PSA. Okay, but BPH, yes. And the other things are infection and catheterization and acute retention. Okay, so you need to know these common things. Okay, so you do a PSA and PSA is normal. What else you want to do here?
I would like to do an ultrasound scan of the. I would like to do an ultrasound scan and to see the residual volume and prostate.
Ultrasound scan where? Ultrasound scan where?
Of the kidney, ureter, bladder, and the prostate.
Okay. Anything else you would like to see in the ultrasound scan important in this patient's management?
If there is any upper tract dilatation.
Okay. Okay, you would like to see any upper tract dilatation. What else you would like to see?
The bladder wall, the status of the bladder wall.
Bladder wall thickness?
Yes.
Upper tract? What else?
And the size and volume of the prostate and the residual volume.
Prostate and the residual volume. So you always ask for ultrasound KUBP plus postcoital residual volume. And what else?
I would like to take a X-ray KUB to exclude any bladder stones.
In the ultrasound scan you can see whether there are any other organ involvement. Okay, right. Right. X-ray what?
Kidney, ureter, bladder.
To see what?
Sorry, sir.
To see what? Ultrasound. Sorry, X-ray KUB to see what sort of things?
If there are any bladder stones.
Okay.
And once again, it can show any upper tract dilatation.
Okay. Right. So so those are the basic things that you want. Upper tract dilatation, you can't see it in X-ray KV, but if you suspect prostate cancer, you can be a little bit smart enough and tell what sort of findings in the prostate cancer. If it's an advanced prostate cancer, what are the things that you would expect to see in X-ray? A little bit of pathology.
In the X-ray of the KUB, sir?
Yeah. If there are bone mets,
there will be.
You heard of a sclerotic bone met?
Yes, osteosclerotic deposits.
Yeah. Okay. All right. Okay. Right. So this man has got PSA of normal value, and his creatinine is normal, and ultrasound shows 50 grams of prostate and residual volume of 50. Can you tell me what sort of management would be best fit for this man?
Sir, can you please come again, sir?
Yeah, if the ultrasound scan shows 50 grams of prostate, let's say slightly above the normal value, and then a little bit of about 50 ml of residual volume, serum creatinine normal, PSA is normal. What sort of management do you think this man needs? What is your mainstay of management, in other words, if I ask you? Does he need surgery?
Since we can, it's like if the patient is with mild symptoms,
Okay.
we can go for conservative management.
Okay. So it depends on the severity of the symptoms. Okay.
Yes. We can
Two important things.
Yes.
Okay.
So we can get a semi-objective assessment of the patient's severity with the score like IPSS, and if the patient has if the patient
What
has
is
milder
IPSS? What is
international prostate symptom score.
Okay. All right. So at your stage, you need to know what two things will decide on patient's management strategy. What are the mainstay of management of a patient with a BPH?
We can
what main modalities?
There's pharmacological management, and then and then we can go to operative treatment with transurethral resection of the prostate.
Okay. Can you tell me what are the indications for surgery? Just a little bit of an advanced question at your stage, but you need to know because when you manage this patient, you need to know which patient needs to be referred for surgery. Do you know what are the contraindications for medical management?
The indications for surgical management would be increased severity of the symptoms, or failed drug treatment, or the prostate less than so increased severity of symptoms and failed drug treatment, or if there are other complications of benign prostatic hyperplasia such as acute retention, chronic retention, or recurrent infection.
Okay, and then the upper rectal patient and renal impairment. Okay, right. I think the 10 minutes have already gone. Pramod.
Yeah, so I mean, we'd like you to continue the management part, I think, for the benefit of the students. So important thing is that we've discussed there is medical management and surgical management, and we have discussed the indications for surgery, right? So get that clear into your heads, students, when and where surgery is indicated. Shall we discuss a little bit about medical management as well? I think as per the investigation findings you gave, this patient can be managed pharmacologically, isn't it?
Yeah, definitely. So you need to know.
One thing.
Yes, sir.
Yes, Nisha. Now, benign prostate hyperplasia it's not a deadly disease, not like colorectal cancer. So the management basically depends on the complications as well as how it bother the patient, or how it affects his day-to-day life, sort of how much he's how much he is affected by this disease. It is good sort of the student paid some attention in the history, how it affects his day-to-day life and sort of what sort of things he missed because of this disease. But I think she's quite okay. That is a bit of a good to know, and or even beyond that, because it affects the management, isn't it? So even not without that sort of he can proceed up to a 60, 65, but to score beyond that, I hope sort of they have to sort of pay some attention how it affects how it affects the quality of life and how much it bothers his day-to-day life. And what's the place of now the investigations you were asking, but is it front?
Sorry, I didn't get your question. Hello.
Oh, the investigations you were asking, what is the place for uroflowmetry in this sort of a patient? Is it a frontline investigation,
Right.
or is it an optional?
I would say it's an optional investigation because uroflow is always important when you wanted to have a subjective assessment, some sort of an objective assessment, because all the symptoms now for the students, it's quite important to know the fact that this is well, as Sulusa said, there are two important factors when it comes to when you manage this patient to decide on whether you're going to go for some sort of a surgical intervention or you're going to manage medically. So if you take somebody who's got, so there are two factors. One is the symptom severity, which includes sort of, if you look at the IPSS score for people who are interested, IPSS score incorporates two things as symptom severity. One is the LUTS score of the LUTS symptoms, and the second thing is the bothersomness, as I said, right? So based on those two factors, you get a score. So you know that when the patients are giving history, they're going to tell various things, but you know, this sort of standardized questionnaire, like a scoring system, will give you a more of a standardized way of assessment. So give a score based on the severity and the bothersome of the symptom. So that's the one important thing. Second thing is the complications, whether there are any complications. So you need to know, you need to ask the patient, because that is important. That's why we were stressing the fact of recurrent UTI, and whether he has got recurrent history of acute retention, right? And whether he has got bladder stones, right? Because that is another indication for surgery. If there is a bladder stone with bladder outflow obstruction, if you just go ahead and treat the bladder stone, the stone will recur. Because why there is a bladder stone? Because there is residual volume. And you know, in a basic science, whenever there is some hollow or viscous, it's not emptying, even in a gallbladder or it may be bladder, or wherever the place, even in the salivary glands, if they're not draining, they're more prone to develop or produce stones. So that is one important thing. So the complications. So those are the two factors, severity as well as the complications. You need to know, you need to read about the complications of bladder outflow obstruction or the BPH, right? So that is very important. I would like to show you like to talk to you about a few things about uroflowmetry since just asked. So uroflowmetry is an investigation, I think you can say, right? So where you ask the patient to void into a funnel, and then we get a nice graph. By looking at the graph, somebody who's experienced can say whether there is this is the usual normal graph, but if you look at the Euroflow, let me just say, if it is a stricture, you get a pattern like this, a flat line, right? A little bit of a sawtooth-like appearance or a flat line. So that is one way that we can diagnose the stricture. It's just an anecdotal findings, anecdotal evidence. But yeah, but in a normal man, it will be like this. But in a BPH, you get a troughs and peaks, troughs and peaks, troughs and peaks, and then it goes off. And sometimes you have a little bit of a sort of delayed empty. So by looking at uroflowmetry, a person who's experienced can give some sort of a idea what is going on inside by looking at the flow. So uroflow is an important thing. Few things about the BPH related complications who can't be managed medically. These are some of the slides, example slides I just found from various during my in my presentations. So you can see acute retention. First time, yes, you can give a course of tamsulosin and give them a trial of void, and then see whether you can manage the patient medically. I mean, if the patient has got acute retention of urine until you decide on, until the patient undergoes surgery, if that is not going to happen, patient should be on lifelong tamsulosin. We have seen many patients in general surgical wards who've been given tamsulosin for 1 month, and thereafter patient will come back again with another episode of retention. So tamsulosin would be a lifelong if you are giving them for acute retention of urine or severe low nitric symptoms, unless you are going to go for surgery. Then I wonder whether you're familiar about the uh, definition of acute retention of urine. I would like you to have some sort of a idea, because sometimes you can have patients in a long case, patient who's admitted with acute retention on a catheter, and those patients can be given at your exam. And then we'll ask you what is the definition of acute retention urine. So you need to know, is acute onset, painful, inability to pass urine with palpable bladder. So all these 4 features should be there. And if you can, these are kind of questions that you need to know. I mean, it's a kind of a core knowledge. So if you can't answer them, you will definitely lose marks. So you need to know what is the definition of acute retention. Okay. So the other complication is the chronic retention. Yeah, usually these are the patients who've got upper tract dilatation with very high residual volume. The other things like bladder calculi, recurrent UTI, and also some people with BPH, even BPH can have recurrent hematuria if you exclude everything else for the cause of hematuria. So those patients also should be considered as BPH-related complications, and they can be offered surgery. Okay, and they should be offered surgery if there is a anything else I would like to say? What
Shall
about the
we touch
medical
on
management?
principles of medical management as well?
All right. Okay. Right. So whether there are any conservative management options, you could always, one of the important things is the fluid management. These are the type of patients who could sort of, that there is a common misbelief in our society and in our sort of many other media that if you have a urine problem, you need to sort of drink plenty of water, right? But this is one of the conditions. If you drink plenty of water with a bladder outflow obstruction, you will be getting up in the night, all night, and go to the toilet about 5, 6, 7, 8 times. So these are the kind of patients you should ask to drink to their thirst and not to overdrink. Okay, and then again, anything like caffeine and any other alcohol like bladder irritating substances. So there is a element of conservative management. These are the advices that you should give, right? And I will not go into details, but then we'll just touch upon the medical management. You know that in exam, you should be sometimes, we are not always going to give you the same scenario, and we might sort of, we get the same case for 10 candidates. So we might skip everything else and you start with the medical management. Okay. We'll just ask you, okay, give us a sort of summary of medications available for management. So we have alpha blockers and 5-alpha reductase inhibitors. Those are the 2 main things. Forget about the PD5, that's not for you. So those are the 2 main things that we give for BPH, if it is BPH, right? And yeah, and then we nowadays we don't give sort of, there are various other preparations historically, but now we are concentrating on 2 main things, that is tamsulosin and the silodacin. So at least you need to know what is tamsulosin, and that is a highly selective alpha-1 blocker, right? So if you look at the, now in this slide, if you can see, these are the sort of alpha receptors in the bladder and the prostate, you can see alpha-1A receptors are the ones concentrated on the bladder neck as well as in the prostate stroma, right? So whatever the drugs you are going to give, it will be highly selectively act upon the bladder neck and the prostate stroma. So that is going to relax the prostate, relax the bladder neck, open up the bladder neck, and let the patient void. Okay, so that is one of the important things. And the second important thing is the 5-alpha relaxation inhibitor. Now, this is not something which will relax the prostate. It has a long-term effect, right? So the main action is the shrinking of the prostate. So you can see, and because you need to know a little bit about 5-alpha reductase, that is going to inhibit the 1-alpha reductase, and then that will sort of prevent the formation of the dihydroxytestosterone locally inside the prostate gland, so that the prostate gland will shrink. So that is a disease modifying drug rather than symptom relieving drug. So if you give long term, that patient might not need any surgery in the future, right? So that will prevent the progression of the disease. So if you know few things about that, that is good enough. Like, shrinking effect and disease modification, that's what we want to know. That's nothing else at your stage. Okay. So yeah, we forget about the other things. So we know these indications for surgery. Then we might ask you about few things about what are the options available, if you know anything. So you can broadly say TURP or transurethral resection of the prostate. And then there are many other ways. So you just need to know lasers can also be used. So that's just nice to know. But if you can tell TURP, we don't do open operations. We very rarely do open operations for prostate now. So you just need to know TURP as one of the mainstays. Okay. Then yeah, just to tell you about what is going to happen with the prostate enlargement, I'm just going to highlight two things in the ultrasound scan here. So you can see in the ultrasound scan, now this is a normal prostate here. In the ultrasound scan findings, what you can see is an enlarged prostate. So what is the normal size is around 20 gram to 30 gram. But when it becomes bigger, it will become 40, 50, 60. But what you have to know is size has got not much of importance of the symptoms. Like, you might have 80 gram of prostate, but you may be completely asymptomatic. That is only important in the management, because if it is very large, QRP would be challenging. Okay. That's why we are interested in size of the prostate, not to, there's no correlation in the size as well as the symptoms. Okay. Then you can see now because the blockage is here, bladder works extra hard, and the bladder muscle is quite thickened and stiff, and that's why these patients go and pass urine many times, because they can't accommodate the urine because it's stiff. Otherwise, it'll be just nicely relaxed in the bladder fills, and they can accommodate a lot of urine. But here, bladder wall is quite stiff, and that doesn't allow the bladder to distend, and the plasticity is lost, and you need to go and empty your bladder, right? So that is one of the reasons. And then you have a lot of residual volume. So these things can be seen in the ultrasound scan if you ask these things, right? And of course, there are two kidneys. What happens, I'll just show you a couple of slides. What happens when the residual volume goes up and up and up, that where you get into the level of chronic retention, and then that is going to affect your upper trend. So that's a different complication, one of the complications of BPH. So that is the other end of the spectrum, or the severe end of the spectrum, and that's where the patient will have some sort of renal impairment. Okay, so okay, just because this one pop up. Now I'm sure you have seen many of transurethral resections. This is just have a look at this one. This is one of our cases in Radhapura. So you can nicely see how big is the prostate. Can you see huge prostate lobes? These are the two lobes. And then now we are entering into the bladder. Now look at the amount of muck and stuff, and that is because of the high amount of residual volume. This has formed a soft stone, And now you can see how one of the indications of how thick the bladder wall. If you look at the what are these? These are called diverticula, right? So because bladder wall is so thick, mucosa has bulged out of the bladder wall, so forcing diverticuli. And these diverticuli harbor a lot of residual. If you can see, lot of stuff coming, muck and infected material, right? So these type of patients, there's no place to drug management, right? If you look at the ultrasound scan, these are the patients who have very high volume or residual volume, often catheterized several times, right? So that's one of the ureteric orifice. So what we need to do here is a TURP, or just the video will just go on. So you can see how the obstruction is, and that's where the surgery is indicated. So these are the cases, extreme cases. But what we do is we just resect. Now we can see that is a sphincter. Now you can see a nice arch there. That's a sphincter. Obstruction is above that level. So we just resect them. We resect piece by piece, endoscopically, completely endoscopically. And at the end of your resection, your sphincter is not going to be affected. But let's just skip the video. So at the end of the resection, you get a nice prostate cavity. So the obstruction is revealed and then relieved, and the patient can pass urine normally. Now you can see once you do the TURP, there is that's a sphincter. Sphincter is not affected, and there's a nice cavity, and there's no obstruction, so that the urine will pass without any difficulty. So that is one of the very rewarding operations. Um, then, this is just a case scenario. You just to highlight how important and just to make you aware that there is a condition called chronic retention. Yeah, you can see some patients, if you do an ultrasound scan, they might come up with very high residual volumes, right? 900, right? The normal capacity of the bladder is around 400 to 500, right? So if you put a catheter of a man who came with a retention and the bag just filled up around 1000 ml, that man is not having acute retention. He may be having acute on chronic retention. So you need to be aware about this residual volume. That's why we are interested in residual volume, right? And also ultrasound scan, that's why you're interested in upper tract. Sometimes you can have bilateral hydronephrosis and hydrouria. So that is a case of chronic retention. Most of the time, they can come time to time with acute retention episode on top of chronic retention. But if you look at the creatinine, these are the type of patients. That's why we ask, that is the important point that we highlight, that you need to do creatinine. So you get elevated creatinine with the upper tract obstruction and dysfunction, renal dysfunction, okay? And the residual volume, high residual volume. So these type of patients need the catheter, and there's no place for TWOC, right? If you are managing, if you're the house officer, that's one of the important things, right? So you need to always, we just want everybody to document the amount of urine drain. So this is a case of chronic retention. If you look at the bladder, look at where the bladder is. It's huge. It's like a pregnant uterus, right? So that is what is drawn in the other side. You can see a thick bladder wall with trabeculation, and then both the kidneys are sort of obstructed and dilated. So high residual volume will transfer the pressure into the kidneys. Okay, so that will cause renal dysfunction. These type of patients, again, you can easily pick them up. Anybody around 800 of residual volume or above is at high risk of chronic retention, right? These type of patients, there is no place for TWOC or trial without catheter with tamsulosin. These type of patients need surgery. So they should be referred for surgery, right? Otherwise, they will have long-term renal impairment. So anything else I wanted to highlight? Okay, we asked few questions about the PSA, right? Now, PSA is a very widely done, but you need to know what are the false elevations of the PSA. If you, let's say a patient who's had an acute retention and you put a catheter, and then if you send a PSA, that is a wrong practice due to two things. One is the catheter itself will increase the PSA, and acute retention itself will increase the PSA. So if you put a catheter, if the patient has had acute retention, defer the PSA for 2 weeks at least. Okay. And the other thing is you need to know whether there's an UTI and prostatitis. Ejaculation, not that much. But DRE, again, it's a misbelief, right? So none of these things cause a significant high level of PSA. Then again, okay, we just discussed about these investigations. Now, how do you diagnose a urethral stricture? That is again one of the important thing. That is, of course, that is where the history comes very handy, because urethral strictures are very difficult to diagnose if the patient is old. But if the patient is young, there is a high chance, I mean, it's very unlikely that patients are below 50 years of age to come up with urethral stricture, right? So anybody below 50 years, there is a high chance he may be having urethral stricture. So you need to think of those things when you are looking at them. But anybody above 50 comes with stricture or BPH, very difficult to diagnose unless there is a the positive history like falling asteroid, pelvic fracture, history of RTA, and fallen from height. Those are the patients. And then you can see, if you do a uroflow, you can see a flat pattern, and then usually they have a high residual. And those are the patients, those are the only indication that if you want to do a flexible ureteroscopy, that is one of the indications for flexible ureteroscopy, which you can see whether there is any stricture. Okay. Yeah, anything else I need to add? Yeah, I think that's all about the thing. Whether you need to know anything.
Students have asked few questions.
Yes, please.
When PSA is normal, can we rule out prostatic cancer?
Yeah. Okay, one of the important things is that most people, most of the students think that prostate cancer is sort of PSA specific, right? It is not PSA specific. And the other thing is the commonest presentation. One of the questions that we asked in the in final MBBS also is what is the commonest presentation of prostate cancer? Commonest presentation of the prostate cancer in everywhere in the world is asymptomatic incidental prostate cancer, right? None of them are symptomatic. So, so when you ask about the question was when the PSA is normal, whether you can rule out prostate cancer. Two things that you need to know when you talk about PSA. One is the age. Second is the size of the prostate. So now, if the size is very large, because we know that the BPH or benign prostate hyperplasia can also increase the PSA. So if you get 100 grams of prostate, you can invariably, when there's no cancer, you can have around 8-10 of PSA even in a normal man, right? But it's very difficult to sort of, go case. It has to be case by case. But if the PSA is normal, that is, you had to know what is normal for what age group, right? So you get, for example, if you get a 40-year-old man, normal PSA is less than 3, okay? Or less than 50-year-old man, normal PSA is less than 3. Less than 60-year-old man, it will be less than 4. When it goes to 60, 70, then only you reach 60 to 75, and then you slowly get high range. So according to the age also, the normal cutoff value of PSA will go high. So one important thing is what is normal for the age of the patient and what is normal for the size of the prostate. So that is why PSA is not a very good investigation. So you have to always combine it with digital rectal examination. So if the PSA is normal and digital rectal examination is also normal, at your stage, you can say, okay, this man most probably 90% of the time having a not having a cancer, right? But you have to combine those things together, okay? So then comes the question, what happens when the PSA is high for the age range? Then that is the indication that where you need to do further investigation. So what is the commonest investigation which we do for a patient who's got high amount of high level of PSA for his age? That is at in our country, in our setup, is still what is called a transrectal ultrasound scan and biopsy of the prostate. We call it TRUS biopsy, transrectal ultrasound guided biopsy of the prostate, which can be done as in a local anesthetic setting, and where we sample few cores of the prostate gland either side, and then we look at under the microscope to see whether there is any prostate cancer. So that is, I hope that will be suffice. Anything else?
I've asked what is the place of PSA velocity, PSA density, PSA free, and total ratios.
Okay, all right. So those are kind of, well, if you can come to that level of discussion, you need to know that you're through the exam, right? So, right. So what we've just talked about is the pitfalls of the PSA, because of this non-specific nature of the PSA, people have find out various ways to refine the value of the PSA, right? So whereas now, if you take, there are various refinements. One is what is called a PSA density. I just told you that if 100 grams of prostate can have 10 ml per deciliter PSA, which could be normal, because when the size of the prostate increases, the PSA will also go high. So that's why you need to have density. So density will add the dimension of the size of the prostate. So for example, if you have a small prostate and high PSA, there's a high chance of having prostate cancer, right? So that's the answer for that. Then PSA, other what you said is the PSA velocity. PSA velocity is actually, now again, normal prostate year by year will have BPH, right? So when you get BPH, the glands become bigger, and annually, as the gland size become bigger, PSA will also go up and up. But if you get a prostate cancer in that gland, it's not the same rate that the PSA will go up. So if you annually measure the PSA, like in a man with a borderline PSA, if you are not sure whether this is due to a prostate cancer or BPH, you can annually measure it and see how the rise is. So that is one way of refining it. And free to total ratio, again the same. In a BPH, free PSA is higher, but in a prostate cancer, free PSA is less. You know that the PSA can be combined to the circulating proteins as a combined fraction and also free fraction. So that is, those are all called refinement, because PSA is such an unreliable test. People have find some ways to refine it to make some sense. So that is all these things that you asked are the refinements to sort of go for a more of a high suspicion of a prostate cancer by using the given values of PSA and other few bits and pieces of information you have in your hand. Yeah, anything else?
Another question, how long should the catheter be kept after an episode of acute retention?
All right, okay. Yeah, so after acute retention, the usual guideline says even 10 days is good enough, right? So, so I would say 10 days to 2 weeks. So 2 weeks of treatment and removing the catheter is good enough. So 10 days to 2 weeks is usual time, but you need to make sure that, because what is important is that you need to know what is the sort of half-life of the tamsulosin. Tamsulosin will take about 2 to 3 days to achieve a good level of drugs inside the body. So you need to give them at least, wait for about 10 days to 2 weeks. Then only you should remove the catheter. Any other questions? Somebody asked about the high pressure retention and low pressure retention.
Brief account on high pressure and low pressure transmission.
I think I'll just answer part of that thing. So when you have very well, the bladder can be let's say chronic retention can be of two types, right? What do you mean by chronic retention? Bladder get distended and above the capacity of the normal bladder. And some of these bladders can sort of accommodate the urine, even if the bladder gets distended, the pressure doesn't go up. Those are like, like a shopping bag type of a bladder. We call them kind of atonic bladder. So we call them detrusor failure, right? Chronic retention is detrusor failure. So those bladders are like shopping bags, right? They can accommodate, but the pressure doesn't go up. And at the same time, because the wall doesn't have any contractility power, they can't empty the bladder. But these are harmless because that is just going to accommodate the urine. The pressure doesn't go up. But there is another category of chronic retention bladders, which has a good high volume, high tension inside the, which retains the sort of contractility of the bladder wall. That is more common. And those are the bladders which has got high pressures inside the bladder. So these are chronically retained, but as I showed you, the bladders are at the level of the umbilicus or maybe more, and the pressures are very high. Now there you get reflux of the urine, and at the same time, because the bladder pressure is very high, as you know, the urine will drain into the bladder using peristalsis, right? If the peristalsis can't overcome the pressure inside the bladder, automatically the drainage will stop or hinder, and then slowly the hydronephrosis will settle in, and then slowly they will have renal dysfunction due to hydronephrosis. So that is what is called a high pressure retention. Out of that, high pressure is dangerous because that is the one usually associated with hydronephrosis and renal impairment. Okay.
Right.
Is that to just mention outline surgical options in prostate carcinoma?
Diluk, I think we have now gone past 1.5 hours.
Yes.
So shall we ask them to email Dr. Nishant if it's possible, or contact him online? Is that all right?
Yeah, no problem.
Yeah.
Yeah, no problem. Yeah. Anybody wants to
we will give them the
you can
email address. You can forward, so leisurely when he has time, he will reply to your queries. All right?
Yeah, no problem. I'll just post my email address here. You can all right, okay. I'll just post it here. If you have any questions, you are very welcome to post me any questions. I'll answer you whenever I have the time.
Yeah. So,
or at least I can direct you to read.
Yeah.
Okay, Nishant. Thank you very much for participating in this Zoom meeting, and on behalf of the Department of Surgery, I would like to thank you in, and this won't be the last Zoom meeting which we are going to have you with, and we will have more and more. And thank you very much again.
Yeah, it's a pleasure to join with you all today, and thank you, sir, and thank you, Pramod, for giving me the opportunity. I'm very happy to sort of provide any support that you need. Yeah.
Diluk, we will email all the questions that we didn't answer.
Right, sir. Right. Okay, sir. Okay.
Okay, thank you very much.
Okay, good night.
Thank you.
Good night.
Thank you.
Thank you, sir.